By 2013, primary care trusts will be scrapped. GPs will hold the purse strings for commissioning most patient services. And one of the potential benefits of this is that GPs should be able to react much more effectively to their patients' needs, directing resources into specific areas of care. A consortium in Solihull has been managing care like this for 2 years now, and its work in helping to prevent a killer condition is a great example of how this new system might work. Since 2008, around 20 GP practices in the South Solihull area have been part of the Sirius consortium. The consortium has recently created a revolutionary and cost-effective pathway for the speedy diagnosis and treatment of deep vein thrombosis, or DVT.
We'd realised for a long time that deep vein thrombosis, clots in patients' legs, is very common. We were encouraged by national guidance on care close to home to see if this is something that we could take out of the hospital setting and identify and treat entirely within general practice. In fact, 335 patients per year were turning up at Solihull A&E with a suspected deep vein thrombosis. So that set us thinking that perhaps we could look at this. Why couldn't we do it in general practice? Even better, if you have got a deep vein thrombosis, why couldn't we start the anticoagulation? So that's what we set about to do.
The idea was to create a one-stop service, reducing anxiety and reducing or avoiding the sometimes lengthy process of being referred to a hospital for treatment.
GP surgery, rather than referring to the hospital, refers to the Solihull Healthcare and Walk-in Centre. Previously, patients were transferred from the relative serenity of a primary care environment into a hectic, dynamic and potentially frightening secondary care unit, whereas now they come to just another GP centre really. They're seen at an allocated time, so waiting times are reduced, so it's not as intimidating or frightening for the patients.
Lorraine Hollis has a suspected DVT and her GP has referred her to the walk-in centre. After an examination there, she's sent to have an ultrasound scan at the hospital on the same site.
Okay, then, so some cold jelly coming on your leg now. Ready? Cold jelly. I think for the patient it's excellent because we used to have they were all done within 48 hours because of the risks involved with a DVT. The new pathway now via the walk-in centre, patients are usually scanned within 24 hours. What we need to do is roll you over so we can have a look at the back of your leg. We received the card this morning. She had a phone call to come this afternoon. She'll now go back and the results will be available by the time she gets back. So she'll have an official version of the verbal report, and then any follow-up that she needs, the doctors will put in place today. No blood clot there today. Full report will get sent over now to the walk-in centre. By the time you get yourself back over there, that will be on the system. The doctor will go through it in more detail with you. Okay? Well, there's no worry. We're limiting the risks by seeing them as soon as possible.
The majority of patients referred to the DVT pathway by their GPs do not have deep vein thrombosis, but they may have minor, easily treatable conditions. But catching a potential killer early and getting patients with less serious conditions treated quickly is what it's all about.
There's no DVT.
Good.
There's no DVT at all. The scan is absolutely fine. But they did say that they could see some free fluid in the tissues inside, which suggests cellulitis. And the treatment for it is antibiotics. Okay.
Well, I'm very pleased because the longer you have to wait, the worse the pressure builds up. And because this was very quick, I didn't have too long to worry about it.
It's a win-win system all around, really. It's helped our colleagues in the secondary care sector and the hospital sector in that it's allowed them to target their resources on patients that are perhaps more unwell and has taken some of the strain off their service. It's been great for patients. It's far more convenient. It's a far less intimidating environment. It's great for us at the walk-in centre. Our clinicians really enjoy doing the work. They find it challenging and very different to what a typical GP does. And it also is very well received by the local GP community. They really like the service. They find the whole referral process very efficient and they like using it.
Peter Weston did have a clot in his groin. He believes that the referral to the pathway via the walk-in centre allowed him to receive the prompt attention he required. It was a lifesaver.
Went to see my doctor, who arranged for me to have a scan at Solihull Hospital. I went to Solihull Hospital, had the scan. They diagnosed it immediately as a DVT, and I then went to the walk-in centre, who started to look after me from there. If you go to the hospital, you're just in a queue, and you never see the same person twice. And you felt when you went to the walk-in centre there, you know, it was very comfortable. I mean, I had an appointment every day. I mean, they used to say, right, come at 11 o'clock. I'd get there for 11 o'clock, and I'd be seen virtually within 10 minutes of that, which you would never do if you went into the hospital. It's a very, very serious thing, a DVT. If the process had taken any longer, it could have got very, very serious. As they said at the time, it was stuck in my groin. It had only got to move, and if it had moved up towards your heart, then that would have been a goner.
And it's not just the patients that benefit. There's the potential for massive savings for the Solihull Care Trust.
The cost differential between providing equivalent care in primary care in comparison to the secondary care service, there's a very significant cost saving, which was several hundreds of pounds per patient.
There's 335 patients a year, and we only get half of them going to our community DVT pathway at the walk-in centre. We will save on average £600 a case, which works out at £100,000 a year. The more we send to the walk-in centre, the more savings there are.
In terms of the improvement of clinical care, I really do believe, having worked in the hospital sector, that the patients do receive a better service in the community.
It's a shining example of how practice-based commissioning, and in future how GP consortia can improve patients' health and hopefully do the what would appear as the impossible balancing act of keeping within the financial envelope as well.